rationale for their studies, the results, and really the how it's going to resonate in the community. As always, I'm joined by Chris Cifarelli. Jason Sheehan can't be here today, and we have some repeat offenders today. Rupesh, why don't you introduce yourself and your colleague here and kick us off?
Sure. So thanks for having us here today to present. My name is Rupesh Kotecha. I'm a radiation oncologist at Miami Cancer Institute and lead the CNS team here. Dr. Akdamir, who's going to be presenting here today, is one of our research fellows, is a CNS radiation oncologist himself, and has worked with me on this project, which is data that comes out of a prospective registry that we have been running for the past couple of years at our center. So I'll let him start with the presentation.
Okay. Can you see my screen?
Yes, we can.
Okay. Good afternoon, everyone. My name is
You
Eyüp
want to go into
Akdemir.
yeah. Sorry,
Yeah.
go ahead.
Yeah. Today, I will be presenting the results of our recently published study, which evaluated the use of a digital tablet-based neurocognitive test battery to assess neurocognitive decline in patients with brain tumors. I have no disclosures. Dr. Kotecha's disclosures are listed here. Neurocognitive decline is common in patients with brain metastases and occur even at diagnosis. Surgery, systemic therapies, and radiotherapy may all contribute to neurocognitive decline. Preserving neurocognitive function is critical, as it is significantly associated with quality of life, independence, and patient-reported outcomes. Based on the International Cognition and Cancer Task Force recommendations, longitudinal neurocognitive assessments for cancer patients should cover several domains, such as learning and memory, executive function, and verbal fluency. Traditional neurocognitive assessments are often labor-intensive, time-consuming, rater-dependent, costly, and associated with low compliance. Also perceived too burdensome by patients. Errors in data collection are also concerns in paper-based testing. Even in prospective clinical trials, adherence can be challenging with long-term follow-up. Digital tools offer a more scalable and user-friendly alternative. However, their integration into clinical oncology practice has been limited. Our study aimed to assess the feasibility and clinical value of a tablet-based digital neurocognitive battery in a diverse patient population. We included adult patients receiving SRS, FSRS, whole brain radiotherapy from a prospective registry. All patients had a Karnofsky score of 60 or higher and a life expectancy of at least 6 months. Patients with functional indications for radiotherapy, pregnant patients, or prisoners were excluded. Patients with brain metastases were considered high risk. Those with benign extraaxial tumors such as meningiomas or vestibular schwannomas were considered low risk. We compared neurocognitive outcomes between these two groups and across treatment modalities. A variety of information, including patient-related, disease-related, and treatment-related, was collected. Digital neurocognitive battery consisted of 7 tests corresponding to 5 domains. including learning and memory, verbal fluency, visual motor speed, executive function, and attention and information processing speed. While higher scores indicate better performance in most of the tests, lower scores reflect better performance in number ordering and numbers and letters ordering tasks. Cognition app developed by BrainLab was used for testing. It supports 6 languages and takes about 15 to 20 minutes to complete. Patient complete the practice session and testing was done in a quiet room with trained staff present. Here you can see the tablet-based interface used for digital neurocognitive assessment. The first screen displays patient demographics and clinical details, including diagnosis, treatment time, and functional status. Second panel shows individual test results across multiple domains at a specific time point. And the third view presents longitudinal data, allowing providers to track neurocognitive performance over time. This layout enables efficient, real-time monitoring and supports data-driven clinical decision-making. Here you can see how neurocognitive test battery is progressing. Verbal recall. Patient can record here and symbol match, visual recognition, words that start with, ordering numbers and letters, and usually tests takes 15 to 20 minutes, but it depends on the patient performance. Neurocognitive decline was defined as a significant decline in neurocognitive performance on at least two of the 7 tests. We used Iverson Reliable Change Index to account for practice effects. After baseline evaluation, follow-up assessments were conducted every 3 months. Median age was significantly lower, with a greater proportion of younger and Hispanic patients in the whole brain radiotherapy group compared to SRS, FSRS cohort. Additionally, patients in the benign group, tumor group had significantly higher Karnofsky performance status scores, which is expected. 2 cohorts were well matched. A higher Karnofsky score was observed in the benign group, as I mentioned, and neurocognitive battery effectively differentiated the extent of neurocognitive decline between patients with benign and malignant tumors, 7% versus 36%. Neurocognitive decline was significantly more frequent in patients who received whole brain radiotherapy compared to those treated with SRS or FSRS. 73% versus 27% at 3-month follow-up. Neurocognitive decline continued to be more frequent in whole brain radiotherapy cohort, even when the threshold was set at decline on 3 or more tests. The most commonly affected tests were in the learning and memory domain. Over 60% of patients experienced decline in at least one learning and memory test. However, a subset of patients actually showed improvement in some domains. Among patients treated with SRS, FSRS, many factors were evaluated in the univariate analysis. Prior craniotomy and lower education level were found to be associated with higher risk of neurocognitive decline. However, these associations were not significant in multivariate analysis. We also looked at long-term survivors. While most tests show stabilization or improvement at 12 months, a few tests, such as symbol matching, continued to show decline, indicating the need for long-term monitoring. Patient feedback on the digital tool was overall positive. Most patients found it acceptable, easy to understand, and not burdensome. This supports the feasibility of implementing such tools in routine care. For example, as you can see here, 94% of patients reported questions were easy to understand, and 90% would recommend to others. The tool enables multilingual, real-time, and longitudinal data collection with high compliance. However, limitations include small size of whole brain radiotherapy group, possible bias from digital literacy, and lack of education and language stratified normative data. Our study shows that digital neurocognitive assessment is both feasible and well accepted. It can detect cognitive changes following radiotherapy, particularly in different risk groups, and may be integrated into routine practice to support patient care. Thank you for attention. Here I am sharing our recently published paper, and please feel free to scan the QR code to access the full text, full article.
Thanks so much, Ayub.
Thank you.
Rupesh, great job. Obviously, great presentation. Really appreciate you guys being on. I think, it's very apparent that this study was really to evaluate this kind of novel technique rather than really highlight the findings, right? And that's based on just the control group you use and stuff that we kind of know happens. Early on, you tied in this idea of cognitive outcomes and quality of life. This is obviously a cognitive test. How are you pulling in, whether it's a PRO or quality of life assessments into this, or is there an option to expand it to include those things? How do you work with that data or those data?
That's a great question. So, going back to this for the genesis, the pen and paper based testing, which, is always universally recommended in guidelines, is not really practiced in a clinical sense, right? Very few centers actually offer detailed neurocognitive assessment before and after surgery, before and after radiation. And so, you can see this in consensus papers, and it's always a recommendation on any NCI task force, but really in clinical practice, it's really not followed. So really, I didn't understand the point of that recommendation being kind of universal, and the fact that a lot of our patients do suffer at least some type of neurocognitive decline or dysfunction. So we really started this as a program to say, what is a way that we can feasibly just implement this into the clinic? So this is an iPad-based system. As you mentioned, essentially is delivered in about 15 to 20 minutes. And actually, this can be even delivered at home to patients. You can actually have the assessment timed with a visit as it is. We have not done that at our center. All the patients actually do this during the course of their follow-up visits themselves when they're synchronized with MRI scans. But in addition to this, the first phase was to launch this, and then we did want to launch the collection of other patient-reported outcomes. And patients have been enrolled into a variety of other clinical trials, so we are capturing some patient-reported outcomes. We wanted to also make this kind of a routine part of our care, but then adding patient-reported outcomes on top of neurocog, on top of imaging, on top of clinical assessments, that did become, I don't want to say too burdensome, but that did become complicated and logistically was not really as feasible to be done. I think, now they have more facile ways of doing this. Again, it can be done on the iPad system as well, but I think patient engagement is a lot less. I think at least for neurocog, and as you can see, the way that the system was designed, it is gamified so the patients can get through it a lot faster, and it is interactive. That's different than just filling out a survey about how you're feeling and how pain and how you're functioning and your social quality of life. So that's why it is difficult to assess that.
Yeah, absolutely. Is there a component of this where the patient has to qualify to take this test? So I've used the NIH toolbox in the past, and the NIH toolbox is cumbersome in and of itself, and it's not explained well, and forget elderly patients who are just not computer literate. It's just hard to do, and you bring into the equation a persistent or a present cognitive deficit already. How do you screen patients as to who should take this test or not?
Yeah. As I mean, you have mentioned it, we try to keep it overall pretty broad with the original eligibility criteria for the registry enrollment itself. We do put all of our patients through a baseline test, and part of that is actually just having the patient go through the training procedure, which is a couple of minutes at their first visit. And if they aren't able to complete it, then they're a screen fail for the study itself, and then they will not continue with all of that. That being said, I think that's been a small percentage of our patients. I want to say it's definitely less than 10%, less than 5%. But again, we are choosing patients at the right time as who would be eligible or go on to this. So there is some selection bias from us as regards to who we're going to put onto the registry to begin with.
Yeah, I mean, we're part of a consortium looking at these kind of outcomes with connectomics
Yep.
and brain tumor patients, and one of the screening criteria is basically doing a mini mental state. If you fail the mini mental
Yep.
state,
That's
you can't go on to the cognitive testing,
Yeah,
basically.
that's actually a really great screen, actually, that has been used historically in the past
Yeah.
as just putting baseline threshold for MMSE and then having the patients go on to a cognition study. For other cognitive function or therapeutic interventional studies, that's what we have used as a screening parameter.
Yeah.
We didn't do that for this because we wanted to make this more open and more generic. But we have used that for other studies at our institution that are testing cognition.
Yeah, makes sense.
So, Rupesh and yeah, thanks for a great presentation. You already touched on where you work this into the workflow of, patient follow-up. Um, but I have two questions for you. One relates to the practice effect. Now, this is probably something specific to this software, but one of the obstacles always is you give somebody the same test, they're going to do better. Or are they doing the same and what you're doing is missing the decline because it's compensated for in there? And can you talk a little bit more about your correction for the practice effect?
Yeah. So as with all neurocognitive tests, it's always a test and then retest, and our patients are tested at longer intervals, and so you can account for the same patient on the same test and having some decline compared to their own baseline testing itself. So if they were getting better with time, you'd expect that they're actually learning from the test and just the fact that they're getting better at that test as it is. We've seen this in other aspects, not testing neurocognitive function, but for example, some of these quote unquote brain tumor learning or training, app-based systems, they're really games. And what we see in those when they're formally tested is that somebody's not getting smarter with time. They're actually just getting better at using the same test. So I want to say for some of these, like if you're used to playing Wordle or something else, you're just better at that with time, but you're not any better if we test how many words you actually know or your baseline knowledge, right? Their IQ doesn't go up with time. That's
Sure.
different for these types of tests. Go ahead.
Although if you had somebody, let's say, has perilesional edema that's infecting short-term memory or
Yeah.
speech or cognition, have you been able to capture some of that where
Yes.
somebody improves
Yeah,
longitudinally?
we would. And actually, the interesting thing is if you go back to the data, this is how we parse the data. So we have a couple hundred patients actually who have been enrolled onto our registry for this particular project. We just wanted to focus on the brain Mets patients and really radiosurgery versus whole brain. And if you look at the data that we had, they recapitulate the results that we've seen in randomized trials really well. And those are with detailed neurocognitive tests taking 4 hours. Our numbers are very similar with a 15 to 20-minute iPad-based test. What's interesting is we wanted to create a control cohort as well, just to say, what are patients who really should have no neurocognitive dysfunction? If it tells you neurocognitive dysfunction in everybody, maybe there's an issue here. So our option was either A, we test fellows like you, or B, is we test patients who shouldn't have any neurocognitive decline. We decided, let's just take benign extraaxial tumor patients, meningiomas, vestibular schwannomas. None of them had neurocognitive decline at baseline. So that's number one, which is great. That's what we expect, right? And number two is really just on their test retest. It was 7%, quote unquote. That's actually one patient. And it was one patient only at the 3-month time point. And it was because they had pseudoprogression of their vestibular schwannoma. So they had cystic necrosis in the middle. It enlarged. They had a little bit of hearing impairment at their 3-month visit when they were seen. And actually, they tested worse on their neurocognitive test, quote unquote, because they were slower with that test, just with thinking, because they were having these issues, a little bit of worsening tinnitus. That got better at 6 months, and their test got better, and they went back to zero. So if you look at our extraaxial or benign tumor patients treated with radiosurgery at 6 months and beyond, which is more important, that's when these patients really need assessment, right? These are long-term patients going to live forever with a vestibular schwannoma. There have been no episodes of neurocognitive decline beyond that 3-month assessment. There's one patient, and that one patient only had issues with hearing and tinnitus, which affected their test. And that you'll see in the full publication as well, that we describe that one patient.
Great, thanks. And I'll remind our participants that are watching along in real time, if you have any questions, type them into the chat function, and we'll try to get to them if you have anything that's burning that you want to have addressed by our presenters.
Yeah, Rupesh, and what do you think? You just mentioned it. What's the difference between taking the 4-hour test and this? Why is this so sensitive? Is it designed that way? Is it just the best of the best tests, or how is it being so sensitive? Or at least in your hands, equivocal to the comprehensive battery typically done by neuropsychiatry?
It's very similar, and that's why actually we put in that slide that showed the breakdown. We test all of the same domains that are tested with our traditional tests. If we're thinking about the Hopkins Verbal Learning Test, there are 3 types of that. There's your immediate recall, your delayed recall. The same type of tests are used in this system. And so they're very similar to how the traditional pen and paper tests were designed. That's how these were designed. The unfortunate thing is we don't have the complete validation. For example, it's available in multiple languages, but we don't have this validated over the years like you have with the traditional pen and paper testing. That being said, for example, if you enroll somebody onto an NRG trial right now, you can't enroll onto Spanish-speaking patients, right? You only have English and we have French, because those are the only ones that have been validated over decades of us using these tests for us to be testing our patients in NRG. And so as an enrolling site, for example, when we enrolled patients onto NRG CC003, we couldn't enroll Spanish-speaking patients. 2/3 of the patients on our brain lab tests so far have been Spanish-speaking. Again, in our area in Miami, it's just a language preference. And so these are patients who would have been excluded from traditional neurocognitive assessments who now we're able to measure their assessments. So I think validation work is clearly the next step now that we have proven that there's some signal here. But that will take time and effort again. And how do you validate that in all different patient populations and large series of patients and large series of normative people, not patients? That's kind of a second step effort that will need to be done.
Yeah, well, I want to commend you. Great work. We've got about 5 minutes left for any questions from the group, or Chris, if you have any other questions. This is something near and dear to my heart. When I saw the paper, I definitely wanted to have you guys on. We've spent a lot of time with the Glioma Connectome project trying to find out appropriate neurocog testing. And it's difficult. You've got really, like you said, validated and established platforms for this and pen and paper tests, but it takes a long time. And like Chris alluded to, serially over time, people get better with it. You want to find kind of the right study. So this seems like a very straightforward 15 minutes, gamified. It's exactly, I think, what people are looking for in this realm. And I think it's really important what you guys have done is highlight how important this is to our outcomes research in this population. So I think fantastic job. Just anecdotally, unless someone else has another question, how do the patients react? Do they have fun? Do they like it?
Yeah, I mean, that's actually why we put in this patient feedback survey. So we had found this survey when I started this, that was a validated survey for patients actually completing electronic-based assessments. And so actually, when we started the program back in 2020, we included that as part of all of the patients that went on to the survey. And you can see essentially very high patient satisfaction with completing this kind of gamified test, as well as a high recommendation to others to do it. And we started also doing this with our connectomics patients as well. Our initial pilot project did show very high correlation between connectomic dysfunction after whole brain radiation therapy. Again, we selected out those patients because they're the ones that have the most neurocognitive dysfunction. So we've seen actually a good correlation with that in our connectomics data as well.
Great. Well, Chris, if you have any other questions?
Yeah, no, it's fantastic. I think that there's great potential here, not only to kind of follow neurocognitive changes, but also maybe identify a subset of patients who, at first glance, maybe don't have the performance status that we'd associate with have a good outcome patient for SRS. We're looking at doing this as well with a sort of a prehabilitation assessment in some of our patients that may have some motor function deficits, or really, you look at it and you say, hey, maybe if that one lesion started to respond, that they'd be back at a KPS of 90. So I think this really will give us more information and be a really, really important tool to see if we can tease out where we should be caring for patients and maybe, not necessarily being as aggressive as we always would be.
Yeah,
But
absolutely. I
thank you.
think definitely can be used as a screening tool as well.
Definitely. All right. Well, we'll give everyone 3 minutes of their afternoon back. Rupesh, as always, it's a pleasure to have you on board. Keep putting out great work. Thanks for publishing in the Journal of Neuro-Oncology. Chris, it's always lovely to see you. Ayub, great presentation. And Corey, we'll see you back in 2 weeks with another Tumor Talk.
Sounds great.
Thank you.
Thank
Take
you.
care, everyone.